Good afternoon, everybody.
Hi, thank you for joining us.
Can you all hear? Would somebody send us a little message if you could hear us well?
So today we're going to be talking about West Nile virus. This is, I think, a very good topic for Nebraska and essentially for everywhere. This is everywhere in the country now. So as you come in, we'll put you on mute, and feel free to unmute yourself and ask questions. And especially at the end, we'll give you time to ask any questions you have, or go ahead and type in any questions on the chat area. You can ask questions, and we'll be sure to get to your questions and answer anything that you have. So West Nile virus, it's a very good topic. I think that we get a lot of questions for West Nile virus. It can be kind of confusing. There's kind of some nuances and things that make it kind of unique and interesting, I think. So here's the overview. So we're going to talk a lot about West Nile, and we try to focus on the things that are clinically relevant. So the clinical aspects that when you see a patient, what kind of things are you going to be wondering? What kind of things should you be ordering and thinking about when you see the patient? So a little bit, we're going to touch a little bit on some of these different subjects as we go. So West Nile virus, it's a flavivirus, and so clinically, I just said we're going to talk about clinical things. So flavivirus, so it's related to dengue and yellow fever and Zika, and so it can actually, you can have a false positive test if someone recently had like a vaccination for yellow fever, or recently had Zika or dengue or something if they travel. So flavivirus, that's why it's interesting, is it can react with those and cross-react, and it's not just something to memorize, but it's actually clinically important, I think.
And also it makes sense why they all are from mosquitoes too, because all those viruses Dr. Horn just mentioned, they all are spread through mosquitoes as well.
Yes, they're arboviruses, so they come from arthropod-borne viruses, so from mosquitoes. So the amplifying host, and we'll talk more about all of these, they come, it amplifies in birds. So birds get it, it amplifies, and then a mosquito bites the bird and then passes it to a person. Yeah. Global distribution, and then the geographic foci, it says New York. So it was first seen in the Western Hemisphere in New York in 1999, and then it passed on, and it kind of spread from there.
Yeah, and now every year the West Nile season kind of starts like end of May, and it goes on until the mosquito seasons are over. So it kind of starts and end of May.
Right, so controlling the mosquitoes is a big part of it.
Yeah.
So here we have a picture of a dead crow. So and this is why infectious disease is fun.
Yeah.
Right? So the picture of a dead crow, because when it first was, I think it's in the Bronx Zoo, they were seeing a lot of dead crows. And so the appearance of a lot of dead birds and dead crows kind of made people realize that West Nile was in the area. Now I'm not so sure that you see a lot of dead birds.
Yeah.
Mainly on test questions, I think, for us.
But what was interesting is I was reading about our Nebraska Health Department, DHHS, and they actually apparently track dead birds, and they also trap mosquitoes as well, and then they test for them starting in May for West Nile, which I thought was kind of cool.
Yeah.
I think every state kind of does that too, to monitor the activity.
Yeah, and infectious disease, I think it's one of the only things where we talk about other animals and
Yes.
and mosquitoes, and we talk about birds and other things, and yeah, and I think that's very interesting. I think, and West Nile is first isolated in the West Nile district of Uganda, so that's where it got its name. So birds, so crows, doves, pigeons, it's all over the world, Europe, Asia, Middle East. So infected bird, the mosquito bites in a bird, picks up West Nile, the virus, and then bites a person. And so here's the mosquito, and then it bites a bird, and then the birds can travel throughout the United States or throughout the world, and then gets bitten by another mosquito that picks up the virus. And then when that mosquito bites either a person or another animal like a horse, and there are other animals, but these are the ones that we kind of focus on. So as you see, the dead-end host is if a mosquito bites a person, it can't pick up West Nile and then transmit it again. It has to be really from an animal that amplifies it and has so much of it in its blood that the mosquito can pick it up. So if it bites a person, it can't pick up West Nile from the person and spread it.
And thankfully, though, that if I have West Nile, I'm not going to give it to you,
right?
By any contact, by any means. Yes.
That's a really good point, because as far as questions of does this person need to be in contact isolation? So they don't need to be in contact isolation. If someone in the family gets it, they're not going to, cough or something and spread it to another person.
And that's why I like that dead end host, because once we as humans, when we get West Nile, it just goes away. It just disappears after the symptoms resolve, and we don't spread it to other humans.
And then here's person to person. So when you talk about person to person, blood transfusion or organ transplant. So they don't need to be in contact precautions or anything like that, or respiratory precautions. But if they give blood to another person, or here intrauterine or breastfeeding, and these are kind of newer things I think that were found. It's not so much something that we talk about very frequently.
The blood transfusion and organ, I think they check for things now to make sure when you're transfusing blood. I know you're going to talk about that in a little bit, but our blood that we do transfuse are screened for a lot of different infectious disease, including West Nile as well.
So here's the transfusion-associated West Nile virus infections. So it's first noticed in 2002. Routine screening of blood supply for West Nile started in 2003, and over 2,500 infected products are removed from the blood supply. But this still happens. So rare transfusion-associated events still occur. And so this is something, in a minute we'll look at they actually look at it per state, and they actually guess how many times per state it can happen. And I think Nebraska's at the top.
Yeah.
So Nebraska is a lot of patients get West Nile virus, and they also, so when the number of people that get it goes up, so does the transfusion related infections. And here's testing of the pooled sample can fail to detect the low viremic units. So just like the mosquito can't pick it up because the virus is so low in the blood, our testing might fail to detect it too. Some products are not screened, like granulocytes, and then here's transplant-associated infections. So since 2002, one transplant-associated West Nile virus cluster recognized each year. So it's really unfortunate, if somebody gets a transplant and then they get West Nile.
And what makes it bad is when you're transplanted, you're on so much immunosuppression medications. So if I get West Nile, I probably recover very easily. But when you're getting a transplant with all that immunosuppression and you get West Nile, then it could have severe consequences and have a severe infection. I kind of like this diagram a lot. So how we should think about West Nile is that 4 out of 5 patients that are exposed to West Nile, 80%, will not have any symptoms. They don't even know that they had West Nile. So sometimes we have patients that for some reason we check the antibodies and they have, like, you could see that they have had West Nile, but they have no clue that they have ever had West Nile. So it's 80% asymptomatic. But about 1 out of 5 patients can develop this febrile illness. What we mean by this febrile illness is this is when you kind of feel you have like fevers, muscle aches, headaches. You feel like you have a viral illness, you're just not feeling well. And about 3 to 5 days later, you get better, sometimes a little bit longer. But that 1%, it's about 1 in every 150 patients who are infected, can get a rare but severe infection, neuroinvasive disease, which affects the brain. So you could get meningitis, encephalitis, myelitis, so affects the brain and the CNS system. So when this happened, and we have taken care of some patients that have had this, unfortunately, there's no treatment when you have the severe infections with West Nile. It's a lot of supportive care, and we have had some fatalities, and especially in our elderly population. But mostly the young patient, if they ever did get the severe infection, they recover.
Right, and that's how I think of it: rare but devastating.
Yeah.
And it's people will ask, well, why did one person get really sick and another person doesn't? And part of it is kind of how healthy they are to start with, or how immunosuppressed they are.
Yeah.
And part of it is just luck.
Yes.
It's just bad luck, saying that one person, might get very, very sick, whereas 80% don't even know that they got sick.
Yeah.
and then 20% feel like they've had the flu kind of thing, but it's kind of in the summertime. It's when there are mosquitoes around. So you're not really thinking flu so much as West Nile. But yeah, I think this is a very good chart. I think it's a very good graph, kind of sums up.
So we shouldn't be so afraid. It's extremely rare to get that rare consequences, like less than 1%, but something to keep in back of our mind. Disease in humans, so incubation is about, like, once you get bit, about 2 to 14 days when you start seeing this. Most infections are asymptomatic, like we just talked about. There's 2 forms. West Nile fever, so most common form, resembles influenza. Most infections resolve in about 2 to 6 days. So it depends. Some people will resolve really quickly. Some people, like 6 days. I've had patients sometimes, they still have those muscle aches and tiredness for like 2 weeks or even a little bit longer. Can persist for longer.
Yeah, and this is the neuroinvasive disease. So it's rare. It's the progression of West Nile fever. So they get kind of the flu-like illness, and then it progresses, and it goes a little farther, and then they get neuroinvasive disease. It can be severe, life-threatening. So we usually think about encephalitis, meningitis, acute flaccid paralysis, and so flaccid paralysis, you can get it from different things, from different viruses, but if it's happening during the summer and it's there's a lot of West Nile in the community, you also think of West Nile. And really, if it's West Nile, there isn't really treatment. Like you were saying, you don't really have treatment. But if you know what it is, then you can you wouldn't have to be worked up for other things, and you can kind of.
You probably don't have to give unnecessary antibiotics and stuff. At least you'll have a diagnosis. West Nile neuroinvasive disease, so you get, like we talked about, meningitis, encephalitis, acute flaccid paralysis. Most cases require hospitalization if this is this severe. Sometimes when the infection is this severe, we also have to do respiratory support for our patients. They're intubated, sedated. Many patients with encephalitis have other long-term sequelae as well. About 50 to 75% need assisted living or rehabilitation after this episode resolves. About morbidity and mortality is higher in elderly. And when we mean by elderly, we're going to look at a graph, but it usually affects 60 years of age or higher in a more worse outcomes. And then overall case fatality is about 10%.
Yeah, and I think of this as kind of like, in my mind, it's kind of like the flu, because most people recover from the flu and don't really think much of it. They just think, oh, that's the flu. But I think from our standpoint, when we see patients, we know it can be devastating for a certain number of patients. Infrequently, people can get very sick, and acute flaccid paralysis and neuroinvasive disease for West Nile is kind of the same thing. I think the general population might think West Nile, you get it and you get over it and you don't get that sick. But as far as encephalitis and acute flaccid paralysis, from the family's perspective, it can be just as bad as a stroke.
Yeah.
I mean, they can look just. I
have had cases where patients are in their 30s and 40s, and they're in the ICU for almost a month. Then they go to rehab, and they look, before the West Nile infection, after West Nile, it's like 2 different person, and it's kind of shocking to see young patients have that much of a consequence due to West Nile. It's rare, not to scare you guys, but it does happen.
And as far as clinically, when you see the patient, the white blood cells in the serum, in the blood, typically normal or slightly elevated. When you do an LP, the CSF, with neuroinvasive disease, it'll essentially look like a viral meningitis. So the elevated protein, they can have moderate pleocytosis, so they can have elevated WBCs, but not so much that you'd see in a bacterial infection. Moderate, so they have a predominance of lymphocytes. So usually with viral illnesses, they'll have lymphocytes predominate. However, neutrophils may be high early in the infection. So it's hard to look at it and say it's West Nile over other viral illnesses, but it'll essentially, you'll look at the CSF and you'll say that's probably from a viral illness, and most consistent, especially if they've been out camping or they have a lot of mosquito bites or a lot of West Nile in the community, you would suspect West Nile. Imaging studies, so sometimes people will, with some types of viral meningitis, it has a characteristic look on MRI. I don't know that West Nile has a very something that's very common and frequently seen, but it can kind of be all over the place. You can have focal lesions in the pons, basal ganglia, thalamus, anterior horns. So it isn't something that I would expect a radiologist to look at and say, this is typical.
This is West Nile.
This is West Nile. Yeah. But they would probably look at it and say, this could be West Nile.
West Nile. It's like, yeah. They will say it could be a viral infection of some sort. Some sort of infection.
So you may see something, and as far as should you do an MRI, it kind of depends on the patient. I think that if they're severe, I think doing an MRI is a good idea.
So risk factors, so age greater than 60, diabetes, hypertension, cancer history, so immunosuppressed patients, chronic renal disease, chronic alcohol abuse. So these patients are at high risk for getting the severe West Nile infection.
And this is kind of from the articles that we're looking at the connection with age and severity of disease. So, and this one that's shooting up here, this is encephalitis. So you can see that it kind of shoots up, and people talk about age of 60 being, worsening disease with West Nile. And you can see that it kind of shoots up. So it's still possible to have encephalitis, at a younger age, but the severity as far as age is a major contributing thing that we look at when we think of encephalitis and the higher likelihood in the older population.
Yeah, nicely describes. Older you are, the worse, more likely you are to have the encephalitis and meningitis.
So like you're saying, you saw a patient that was 30 years old.
Yeah, I saw, yeah.
So it can still happen when you're 30. It's just not as frequent as compared with someone's older age. Or, I don't think of being 50 as being very old.
No.
but it's still something that it happens, and then the patients will say, well, why is this happening? And we'll say it's, I think ID doctors kind of say it's a combination of bad luck and kind of your underlying illnesses.
So outcomes. Full recovery is pretty common for most patients, uncomplicated West Nile infections that they have. But patients hospitalized with West Nile virus encephalitis frequently require assistance with daily activity following acute cure discharge, like my patient, and often report substantial functional or cognitive difficulty up to a year following the infection. They not just functional, but the cognitive deficiency, it's slow, but it comes back. Only 37% of patients in 1999, when the New York outbreak happened, achieved full recovery at 1 year, and 53% of the patient in one study reported symptom lasting at least 6 months. So if you have severe infection, expect to have these symptoms last about 6 to 12 months, and it's a slow process to get back to where you were.
Yeah, and I remember, so in fellowship was the first time I saw someone that was younger that had West Nile that was just completely devastating. And the cognitive difficulties, they couldn't speak, they couldn't communicate. Especially for the family, to be so young and then have this happen is really quite shocking. And then transmission. So how do we prevent West Nile from spreading? So it's really controlling the mosquito populations and the spread of the vectors. So here, West Nile virus is maintained in mosquito populations, and once the mosquito gets it, they can pass it from the adult to the eggs. So they don't have to continue biting the birds. They can pass it essentially from the adults to the eggs and keep it going in the community. And Culex is the one that we talk about most. There are many different types of mosquitoes.
Yeah. I just recently learned there's 50 different species of mosquitoes.
Yeah, and Culex, and so there are lots of different types of mosquitoes that can transmit it, but Culex is the one we talk about most.
Yeah, I think Culex species transmit very well.
Yeah, and you can see the different areas of the country that they go. So depending on where you are in the country, the different type of mosquitoes. This is the Culex, and it can be identified by this white patch here. So it has this white spot, and then it kind of has some features. So if you hit a mosquito, if you're out camping, and you hit a mosquito, and you can look at it and say, is this a West Nile one?
Yeah.
I have a lot of mosquitoes around my house, and I actually just did that. I hit it, and I had just been looking at this the other day, and I looked at it. I was like, is that a West Nile one? So if you're really interested in identifying the mosquitoes, I don't know that, I wouldn't send any to the lab to be identified, but yeah. So
this is a nice graph that shows human activity with mosquito, and it goes from like when we first started having mosquitoes in US in 1999 and the cases. So 62 cases, 7 deaths, and then you guys would see in the early 2000s we had lots of cases and lots of deaths.
Mhm.
So this is when we started doing better job with mosquito prevention, better supportive care for our patients who had severe West Nile infection as well. So we learned to do intubation, sedation, keep them in the ICU. So as things like we got better at taking care of our patients, the number of deaths have gone down. Significantly compared to how it was before, 284, 300 deaths per year.
Right, and the deaths coming down. Sometimes I think that's kind of, it's a good thing, but it can be kind of deceptive because you can still have people with long-term disabilities like that 30-year-old that aren't kind of counted here. So it's still, but this is good that the deaths are coming down. And here, the West Nile neuroinvasive disease by state.
So this is for as of January 8, 2019. They're showing the areas. The black areas have the highest amount of West Nile neuroinvasive infections. And if you guys could say in the Midwest area, Nebraska, we had a lot of cases. The next slide kind of goes into exactly, so this is the West Nile cases reported by months. Like we talked about, starts in May, kind of goes off like by end of November when the mosquito season is over. And here is a really nice graph where you guys could see that last year the states with the highest number of cases. So for example, Nebraska, we had 245 cases last year.
So the most in any state.
Any state, yeah. And 11 deaths. And then the second one is Illinois, had 172 cases, but 16 deaths last year.
Yeah, it's interesting. I mean, I think with all the flooding and everything that's been going on, I was thinking we might have more cases, but it's strange. I mean, I would think that with all the mosquitoes, you'd have the most in kind of areas that have a lot of lakes and swamps and everything. So to me, this is kind of a surprise to see Nebraska so high. I think it also kind of correlates with testing. So the more places test and identify cases, the more we'll know that there were actually West Nile cases there. But yeah, I think this is very interesting.
And Kentucky and New Mexico, not a lot of cases, which is good.
Yeah, and here's the presumptive viremic blood donors. So this is how many blood donors that they believe they can't catch them all, and so you'd have to have a high suspicion. But the likelihood of getting it from, and actually, if 80% of the people are asymptomatic, you'd have to be pretty unlucky to get it from the blood, especially if it wasn't picked up with a screening with a low viremic, and then have an actual case and get sick from it. It'd be very low likelihood.
And the other thing too is when we are screening the donor when they're giving blood, if they just got exposed to West Nile, it actually takes about sometimes 7 to 8 days for that test to even show up positive, for our body to react and produce those antibodies. So if you had early exposure, that's why sometimes a screening test might not be accurate initially.
And this ArboNet, this is a surveillance, and it's really good. So I included the website, and they have a lot of information about it. And the CDC, they update it weekly, so you can go to that website, and they'll have it by county. So you can look at your county and kind of it'll track it. So it's actually pretty interactive, good map to go to if you're interested in doing that. And it's a nationally notifiable disease. So when they find cases, they'll actually update it pretty quickly on this ArboNet. So that's a good website if you're interested. Now, diagnosis, serology is the way we diagnose.
Yeah, so serology, basically it's antibodies. So how we diagnose, if you're worried about like a West Nile infection, you should get IgM and IgG antibodies in the serum and in the CSF if you guys are able to do a lumbar puncture and you're worried about neuroinvasive disease. And if the IgM comes back positive, that gives you an indication, okay, this is a recent infection, current infection. But if it's IgG that comes back positive, that's old infection. And then, like John was saying earlier, you can have cross-reaction as well because it's all flavivirus. So let's say somebody just came back from Puerto Rico and they were exposed to dengue, for example, or Zika, and then it could falsely positively say that you have West Nile too. So something to keep in back of our mind. Detection of virus, antigen, or nucleic acid. So you could do PCR testing and immunohistochemistry, but the one that I always use is West Nile serum and CSF IgM serology.
Right, it's serology is the way we do it. And these are kind of like more probably research or something else. It's not something we would use clinically. Yeah. Then here's IgM antibodies and serum or CSF. Presumptive diagnosis of recent West Nile virus infection. And IgM antibodies usually detectable 3 to 8 days after the onset of illness and persist for 30 to 90 days. But it can persist longer. But so if a patient comes in and they're sick, and we'll look at this more. We have a kind of a something that we look at by time, I think on the next slide, where if they come in and they're sick and their antibodies are negative, I would consider, if your suspicion is high, rechecking them, you know, a little bit later on in the course, if you feel like that's really what it was, and it was negative at first, because it takes time for antibodies. Yeah.
And usually what I do is, like, let's say that you guys are strongly suspecting West Nile, and on admission it was negative, but suspicion is still high and you haven't found anything else, it's worth it to repeat like a week later. So then you have given the body enough time to produce those antibodies to see now. So I would repeat it if your suspicion is still wrong, still strong.
And it can last, here it says 90 days. I had a patient last year that came in, he donated blood, and then they sent him a letter saying that your IgM for West Nile virus is positive, and he came in and said, "Is this important?" And I said, "No." I said, "You're doing okay." And he said, "You know, I felt like kind of I had the flu, I think a couple months ago or something." And I said, "That's probably what it was, but you don't need anything for it. You recovered well." So I wouldn't test unless they're acutely sick in the hospital.
Yes.
Yeah. IgG antibodies and serum or CSF suggest past infection. So they were exposed to West Nile virus, their body reacted appropriately and created antibodies. But if they just have IgG and they don't have IgM, that would suggest past infection. Yeah. And then this plaque reduction neutralization test, I just included it just in case anyone's interested. You know, this is kind of a public health thing, but not something that we would use. Yeah.
So limitation of West Nile antibody testing. Serum collected for less than 7 days of onset may lack detectable IgM. So that's how, like, if you're still clinically suspicious, repeat it again a week later. IgM, however, can persist for greater than 1 year. Positive results equal past infections. IgG only indicates past infection. Both IgM or IgG tests may be false positive due to cross-reaction, like we talked about. Blood products can actually contain West Nile antibody and can complicate sometimes their interpretation. I like this graph.
Yeah, I think this is good. So if a person is bitten by the mosquito, and this is the viremia in the blood, so if they get a high amount of West Nile virus in the blood, then the symptoms happen. They start feeling influenza-like, so they have muscle aches, they feel sick, they feel fatigue. So if you were to check them back here when they're viremic, their serology, their antibodies wouldn't be there yet. They didn't have time to develop antibodies yet. And then you have IgM gets high in the blood, and then over here you have IgG. So acutely their IgM, if you tested it, would be positive, but their IgG would be negative, and that would be acute infection.
Yeah.
So I think these are the number of days. So here's they start feeling symptoms at day 0, and then IgM goes up, then IgG, and if you tested them over here, they would be positive for both IgG and IgM, and then at some point over here, their IgG would be positive and IgM would be negative, and that would be sometime in the past they were exposed.
So for us though, if you're worried about West Nile infection for diagnosis, West Nile IgM would be your go-to.
Right, and if you tested it early and it's negative, just like you were saying, if you tested it and it's negative, if your suspicion is still high, if they're still in the hospital for the next few days or next week, it's okay to check it again, and it might be positive at a later time.
So treatment, no specific treatment, unfortunately. Supportive care and management of complications. No proven antiviral adjunctive therapy. Case reports on trial with several therapies, but nothing has been approved or proven to be helpful. No ongoing trials or products for compassionate use yet either.
And here, I just want to include some things that have been tried before. So, ribavirin's been tried, steroids, different immunoglobulins, interferon. So sometimes we'll have someone, one of the clinicians will contact us and say, my patient is very sick. Should I at least try steroids, or should I try IgG or IVIG or something like this? And I think, I try to stay mainstream.
Yeah.
So I have never given anyone like ribavirin or anything like that. Yeah. So some people will say, well, the patient's doing so poorly, I want to give them something. That's true, but if there hasn't been any benefit, and
and it's going to do more harm,
right,
I'd rather not.
I'd rather not. Yeah.
And so the key to all this stuff, I know we talked about how bad this infection can get, but we can prevent it. That's the good news, right? And prevention is by eliminating where mosquitoes can breed. So it's really important around our homes, neighborhoods, to make sure there's no cans, containers, tires, bird bath, unused swimming pool with water. So a stagnant water where mosquitoes can breed. So it's really important for us to eliminate that. So that's one way. Another way to kind of not get mosquito bitten is making obviously the habitat unsuitable. And I know our State Department, they do a lot of spraying for mosquitoes and things like that, so that's very helpful. And prevention in humans, of course.
Oh yeah, so there's no vaccine. I think they might have had one for horses or something in the past, but there's no vaccine to prevent West Nile. Community mosquito control programs, trying to get rid of, just as you were saying, the standing water and things where mosquitoes breed. Household and personal protective measures, so air conditioning, window and door screens to keep the mosquitoes out, reducing the breeding sites with the standing water, long sleeve shirts, long pants, and insect repellents with DEET is one that we'll talk about more in a second, and limit outdoor exposure during peak time, biting time. So if you're going to be on a lake when the sun is going down, it might be very romantic, but if there are a lot of mosquitoes around, it's not so romantic, I don't think. But yeah, and that's in our travel clinic. We'll talk about when people go to areas with high mosquitoes. So some mosquitoes bite during the day, and some bite kind of at nighttime. But really, it's just trying to wear DEET. And if you're going to be around water and on the lake, it's a good idea to just keep that in your mind. It's better to bring something with you rather than wish that you had brought something from mosquitoes.
So personal protection, so wearing long sleeve shirts, pants, limiting outdoor exposure when peak mosquito times. But the repellent that works really well, they have done studies, is DEET. So any product that you buy, if it has DEET more than 20%, like Off, that's a brand. There's Sawyer has another brand that has ingredient called picardiran. So if it has ingredients called DEET or picardiran, they work really well to get rid of, help repel mosquitoes. So mosquito repellent is really important, and you just spray it on your exposed skin. Right? And also, if you're going to, for your face, instead of spraying it, you could apply to your hand and then gently massage it around. Don't put it around your mouth or your eyes. And, it's important to keep it out of the out of children's reach. But then I think adults should apply for kids, making sure they have the mosquito repellent on.
Right, and it's I think with babies,
yes,
it's an important thing as well, because
they say that if you're less than 2 months of age, you cannot use any of these in babies. So you could use DEET and the Percardirin products if you're 2 months of age or older. But if you're 2 months of age or younger, they say these have not been studied. So cover if you're taking the baby out in the, for example, in the bassinet or in the stroller, cover the baby really well so the baby does not get mosquito bites.
And then here, this is just a way to remember it. Drain, so this is where the mosquitoes are. Dress, so it's kind of difficult because if you're going to be out in the summertime, you don't really want to have long sleeves and long pants, but if you're going to be an area with a lot of mosquitoes, is if you can find a lightweight clothes that you can wear to try to prevent it.
That you're saying that, there's actually some clothings now. So there are some clothing manufacturers, they actually manufacturing long sleeve shirts and pants with this repellent called permethrin. So it's actually clothing with mosquito repellent in them. And apparently you can wash these clothing up to 70 times.
Oh, wow.
Yeah.
That's really good.
So if you're going to be in a really bad mosquito area, that might be worth to invest in something like that too.
That sounds really good because when people travel, especially with areas with malaria, permethrin, I think usually in the past they've had to put it into the clothes themselves.
Yeah.
And so I don't know how many travelers would actually put permethrin in the clothes, but if it's already there, that'd be great.
I just found that I don't have any stocks in this company. I just found it really cool that you can wash your clothing 70 times and it's still effective up to 70.
Oh, that's really good. Yeah. And then number 3 is DEET, and number 4 is dusk and dawn, and that's when a lot of mosquitoes are active. And so summary, so West Nile virus remains an important cause of neurologic infections in the United States. It's something to keep in mind if someone comes in with neurologic difficulties and issues in the summertime, if there's a lot of West Nile in the area. 80% of people who are infected will not show any symptoms. So they won't even know they were bitten, or they won't even know that they were exposed to West Nile. No proven effective treatments or vaccines. And it's still important to stop unnecessary therapy. So if they're on antibiotics, if they're getting things, if you identify it as West Nile, you can stop the other antibiotics. Limit further diagnostic evaluation so they don't need to get all the workup. Help predict patient outcomes, so you can talk to the family and say, this is the prognosis, this is, we hope that they get better, they will continue to improve, hopefully. Most people in this situation will continue to improve. However, improvement might be slow. And direct public health prevention measures. So, try and prevent mosquitoes and try and prevent, people from getting exposed in those areas where they can have prevention methods.
So recommendations for healthcare providers: consider West Nile and other arboviral infection differential diagnosis of patient with aseptic meningitis or encephalitis. And I don't know if you guys have heard recently the news and stuff that we've been lucky so far, but in Texas recently they have found mosquitoes with dengue and Zika virus, chikungunya virus, not Zika, chikungunya. So these are infections we haven't had in United States.
And a lot of the mosquitoes are the same mosquitoes.
Same mosquito. So
it's the same.
So their case has been reported in Texas with dengue and chikungunya. So it's really important to think about these West Nile, but keep in mind the other stuff around too. So mosquito prevention.
And I just wanted to say that that's a really good point, that a lot of these vectors of the mosquitoes and with Chagas, the reduvited bug and everything, they're moving north. And so as the world is kind of heating up, you're kind of having these mosquitoes that we never used to see coming this north, coming up, and we're getting a lot of infections. And as these mosquitoes move north, as the bugs kind of move north, as everything is heating up, we're seeing it, and this is something that ID, they keep coming out with different types of diseases that are moving north, and things that we've never seen before.
Because dengue and chikungunya, when we were learning, it's always in other places. I know they had some in Puerto Rico, but never in Texas. So for me to read about that, I was just like,
it's quite shocking when you first start seeing this, but more and more, it's in the ID literature that's all of these things are moving kind of into Canada too.
Promptly report cases to your state or local health departments and allow appropriate control measures and obtain appropriate specimen for laboratory testing.
And if you have any questions about, CDC is very good. The CDC is very, current and up to date, and they I think that's the best site to go to for more information. So the CDC, I just wanted to say that, you know, that's where we get a lot of our information, and that's where I'd recommend going for more information. And here's the mosquito with the white patch here, and it's proboscis thing here. So yeah, if there are any questions, please. So
that's the end of our presentation. So feel free to unmute yourself and ask questions, or you guys could type in some questions. Happy to answer. And also, please let us know what topic you guys would like us to cover in July. If you guys have any topics that you would like us to cover, we're happy to do it in the next coming months.
Right, and I think West Nile is a really good one that we like it when the clinicians think about it, because if they don't think about it and add it to the CSF, you know, one of the tests on the CSF when they do an LP, or even to think of to do an LP, because sometimes it can look so much like a stroke that having an LP, testing for West Nile. So I think it's really good, because sometimes when we don't get consulted, I kind of worry that they might have West Nile, but they're not thinking about it, they're not getting it. So. And
the other thing also is, if you cannot do an LP and you cannot do it in the CSF, it's okay actually to even test it on the serum for West Nile virus testing too. So just keep that as one of your differential diagnoses.
Right. Sometimes it can be hard to get an LP.
Yeah.
And so I think that's exactly right. Yeah.
Well, thank you, everybody. You guys have a great day.
Yeah. Thank you, everybody. And send us any topics that you'd like us to talk about.
And then we'll send this video out. It was recorded. Thank you.